Welcome, everyone. Welcome to Justice and Public Health. We are going to let folks get into the room and get started in just a few seconds. Please grab your lunch, whatever you need to drink as we get ready to jump in. Very excited to have you. All right. So I will go ahead and get started. I do want to wish everyone a happy Wednesday and good afternoon. Before we begin, I want to first acknowledge that the School of Public Health at the University of Minnesota Twin Cities is built within the traditional homelands of the Dakota people. Minnesota comes from the Dakota name for this region, Minnesota Makoche, which loosely translates to the land where the waters reflect the skies. We'll share some concrete resources for supporting our Indigenous relatives in the chat shortly. My name is Lauren Jones. I am the Director of DEI here at the School of Public Health at UMN, and I'm happy to welcome you to the October version of Justice and Public Health. I also want to point out here that we have closed captioning available, so you can access that by using the icon in the bottom right corner of your screen. You can also reach out to Sarah Harris, who is providing our tech support today. We'll monitor the chat for questions as well as share links to our evaluations and information about future events. The Justice and Public Health series started in 2021 as part of the School of Public Health's commitment to justice and anti-racism. We've been hosting monthly events with local and national experts around topics of public health since then. The speakers and presentations in the series help to ground us in theory and in practice, as well as complement the classroom learning that our students experience. We also hope that today's discussion is part of a broader change happening outside of the School of Public Health. If you're interested in staying abreast of other Justice and Public Health events, please be sure to fill out our event evaluation after this and check the box to receive notifications about upcoming events. You may also visit our website at any time. We are recording this event and it'll be on our YouTube site for about, well, until we're told to pull it down, actually. So now I'm going to introduce our speaker for today. Madeline Morcell is a senior attorney at the National Health Law Program. She leads NHELP's work to bridge federal healthcare reform and sexual and reproductive health advocacy, fortify non-discrimination rights in sexual, reproductive, and related healthcare, and advance equitable sexual and reproductive healthcare access for people with disabilities. As a movement lawyer, she counsels reproductive justice organizations on federal, legislative, and administrative matters concerning Medicaid, the Affordable Health Care Act, and civil rights, with a particular focus on immigrant healthcare access. Madeline holds an MPH in health policy from Harvard University, a JD from Washington and Lee University, and a BA in English from the State University of New York at Buffalo. She's received numerous accolades for her work, including recognition as a public health champion by Harvard, the Boston Congress of Public Health's 40 Under 40 Public Health Catalyst Award, CMS's Special Achievement Award and Execution of Major Projects Award, and Harvard's James H. Ware Award for Achievement in the Practice of Public Health. Please help me welcome Madeline Morcell, our speaker for today.
Thank you so much, Lauren. Hello, everyone. I'm going to share my screen. All right. Are you able to see presentation mode, Lauren?
I see it, yes.
Excellent. Thank you so much. Thank you so much for having me today to speak as part of the Justice and Public Health series. My name is Madeline Morcell. As Lauren said, my pronouns are she, her, and I'm a senior attorney at the National Health Law Program. And today I'm going to present on how the forthcoming massive health coverage losses from the so-called One Big Beautiful Bill Act are not the collateral damage of a balanced budget, as some policymakers claim. In fact, they did not balance the budget, they increased the deficit, and they're part of legislated structural violence in our healthcare system that stand in the way of reproductive justice. First, a bit about the National Health Law Program, or NHELP. For over 55 years, NHELP has advocated, educated, and litigated to expand equitable healthcare access for low-income and underserved communities. We work with a wide range of partners nationally and across the country, a wide range of legal services, civil rights, social justice, and anti-poverty advocates, including through our signature Health Law Partnerships program. We also work with sexual and reproductive health rights and justice advocates across the country, including through our reproductive justice movement lawyering and advocacy work, where we take direction from the reproductive justice movement, which I'll talk about in a bit. Our Medicaid doula project, which is in collaboration with doulas and doula collectives and seeks to expand Medicaid beneficiaries' access to doula services, and our Southern Sexual and Reproductive Health Rights and Justice and Medicaid advocates work, where we support and create a space for Southern advocates to work at this intersection. I've also included a link to more information about NHELP, as well as our equity stance that guides our work, which aims to, again, advance equitable access to healthcare, but our North Star in this work is a vision of collective liberation. Today, I'm going to talk about, again, how the federal healthcare cuts that were enshrined in the so-called One Big Beautiful Bill Act that Congress recently passed stand in the way of and deny reproductive justice to undervalued communities. I'm going to cover some key concepts, some historical context for structural violence in federal health policy. I'm going to cover the recent congressional Medicaid and ACA cuts and how they fuel reproductive oppression, a form of structural violence. And then I'm going to share a blueprint for an alternative vision of what federal healthcare reform can look like, the reproductive justice principles for federal universal healthcare reform. Then I'm going to weave it all together and share some resources for thinking about these issues going forward. So first, what is structural violence? Structural violence is a concept that was introduced by Johann Galtung in 1969. This is a form of violence wherein social structures or social institutions harm people by preventing them from meeting their basic needs. This is an avoidable impairment of fundamental human needs. It's often driven by racism, ableism, sexism, including transphobia, and other systems of oppression. And it's often in the form of policy choices that determine who gets sick and who has access to care. So some historical context for what this can look like in health policy. I want to bring us back to the year 1994 and talk a bit about Clinton Care. Clinton Care was an attempt at widespread federal healthcare reform. It was a proposed legislation that was championed by then First Lady and former Secretary Hillary Clinton, and it was a healthcare reform proposal that really failed to address some of the primary concerns of Black women across the country. In the summer of 1994, Black women gathered at a pro-choice conference in Illinois, and they talked about this proposal and these failures, and they decided to organize and write a letter, take out a full-page ad in the Washington Post and Roll Call, which was a Washington-based paper at the time, really critiquing this proposal. And what they said was that federal healthcare reform should include sexual and reproductive healthcare coverage, including care for HIV, for abortion. It should include universal health coverage and equal access to health services, that this coverage should be comprehensive, and that it should include protection for discrimination. This letter was signed by many, many Black women across the country, and this was actually the first action of what became the reproductive justice movement. Reproductive justice is a framework and movement that was first formed by this group of Black women and is now led by Black, Indigenous, and people of color that fights for the human right to maintain personal bodily autonomy, to have children, to not have children, and to parent the children we have in safe and sustainable communities. This framework and movement is separate from the sexual and reproductive health movement and the sexual and reproductive rights movement, even though reproductive justice is often conflated to cover all of these things. It's really important to be clear that these are separate frameworks and movements. Sexual and reproductive health focuses on access to coverage, service delivery, and information necessary to attain the highest attainable standard of sexual and reproductive health. The sexual and reproductive rights movement fights for legal rights to sexual and reproductive health care. It addresses things like bans and other barriers. The strategy is legislative primarily at the state and federal levels, and key players are advocates, legal experts, policymakers, and elected officials. The reproductive justice movement collaborates with these two other movements, but is distinct. It focuses on movement building strategies. It focuses on broader structural factors that shape sexual and reproductive destinies. And it focuses on centering the leadership and power of those most affected by reproductive oppression. What do I mean by reproductive oppression? Reproductive oppression, in short, is reproductive justice denied. It's the controlling and exploiting of women, girls, and individuals through our bodies, sexuality, labor, and reproduction, both social and biological, by families, communities, institutions, and society. And this oppression is maintained by intersecting systems of white supremacy, patriarchy, including cis heteropatriarchy, capitalism, and colonialism. And when institutions and society are the oppressor, this is a form of structural violence. Beyond Clinton care, I just want to offer up some other historical examples of reproductive justice in federal health policy. The first of these is the bringing us back to sort of the first healthcare reform push that really got some traction in the United States. In the 60s, Congress rejected the civil rights movement's push for universal health care in favor of the means-tested Medicaid program and a limited Medicare program that only serves people later in life and some disabled people. Why did this happen? Well, number one, white Southern Democrats, this was in the midst of and right before what is known as the party switch, where the Democratic and Republican Party really switched ideologically. These white Southern Democrats really resisted desegregation in hospitals. And the Civil Rights Act of 1964, which was enacted the year before the Medicaid Act, linked federal funding to racial desegregation in hospitals. And this meant that if we had a national healthcare system that was funding healthcare all across the country, all healthcare providers would have to desegregate, and they didn't want that. The other big factor here was the American Medical Association, which has long resisted the possibility of a national healthcare system, has relentlessly fought universal healthcare, and did so in this case as well due to cost incentives to keep things as privatized as possible. Another example is the Personable Responsibility and Work Opportunity Reconciliation Act of 1996, which was the first big push to narrow immigrant eligibility in Medicaid and other public benefit programs. So I want to talk a little bit before we move on to the present moment about why Medicaid matters. Medicaid was, again, created in 1965 as part of the civil rights movement's groundbreaking triad of legislative victories. While it didn't go as far as what the civil rights movement really envisioned, it truly was transformative in terms of access to care for undervalued communities. And as of June of this year, Medicaid covered over 70 million people with low incomes, particularly Black, Indigenous, and people of color, disabled people, queer people, pregnant people, children, parents, and aging adults. It's a critical provider of sexual and reproductive health care access around the country for people with low incomes. It's the largest payer of US births, covering 41% of total births in the United States and more than 2/3 among Black and Indigenous people. And it accounts for 75% of public expenditures on family planning services such as contraception. So this is an incredibly important program for a variety of reasons for reproductive justice. So, what do the recently enacted so-called Big Beautiful Bill Act's healthcare cuts mean for healthcare access? Well, this law, despite Republicans' repeated claims that this did not include Medicaid cuts, includes the biggest Medicaid cuts we've seen in US history. And I'm going to run through some of these cuts and their details. And then I'm going to zoom out and talk big picture about the magnitude of these cuts. The first thing that I'm going to cover are some of the eligibility cuts. The law requires more frequent and onerous eligibility checks. It will require eligibility redeterminations in Medicaid every 6 months for Medicaid expansion enrollees instead of yearly. It will cut retroactive eligibility from 3 months to 1 month, and for expansion enrollees, and 2 months for non-Medicaid expansion enrollees. This is a walkback that will have pretty disastrous impacts on things like medical debt. It reduces home equity limits, and it prevents implementation of federal regulations that have streamlined eligibility for Medicaid applicants who are older or have disabilities. I want to just note, looking at all of these implementation dates, that these provisions will not be implemented for several years. And that is by design, because the people who designed this law really want to push out the hurt that will come from it as far as possible so that voters and individuals are not aware of what is coming for as long as possible. The other piece here is work requirements. Work requirements are Medicaid cuts by another name. The Congressional Budget Office predicts that 5.3 million people will lose coverage because of work requirements. These are a mandatory requirement for Medicaid expansion and partial expansion enrollees and applicants between the ages of 19 and 64, and individuals will have to show compliance with these requirements both at application, when they apply for Medicaid, and during those frequent renewals that are now required, those frequent redeterminations. What will qualify? Any combination of activities that adds up to 80 hours per month. This can include paid work, community service, or participation in a work program, or enrollment as a student at a university at least half-time. And there are also monthly income requirements that are tied to federal minimum wage. There are some exemptions in theory in this policy. There are pregnancy-related exemptions, exemptions for parents with kids 13 and under, medically frail or special needs exemptions. That is not our language, that is the language in the law. But we know from decades of experience with work requirements in programs like SNAP, the Supplemental Nutrition Assistance Program, and TANF, Temporary Aid for Needy Families, as well as experiments with Medicaid work requirements in states like Arkansas and Georgia, that exemptions don't work for a variety of reasons. There is a lot of red tape. There are issues like caseworker discrimination, and people don't always know that they qualify for exemptions, and so they don't even know that they should apply. There are minimal outreach requirements to explain these new requirements to communities, and individuals who lose or are denied Medicaid expansion coverage due to work requirements will actually be locked out of subsidized marketplace coverage. And the marketplace was created through the Affordable Care Act. There's a national marketplace and there are also state marketplaces, and this is for people who are not eligible for employer-sponsored coverage, but make too much to qualify for Medicaid. They can enroll in subsidized private coverage plans. But under this policy, if they fail to meet the work requirements or are improperly denied Medicaid expansion coverage due to work requirements, they'll be locked out of the subsidies that make that marketplace coverage affordable. The implementation deadline for this policy is the beginning of 2027. There are state options for earlier implementation, so some states may do that. HHS is going to have to issue an interim final rule really describing how this is all going to work by next summer. And it's really important to note that usually rulemakings, which are the process through which the federal government creates regulations that really spell out the details of how they're going to implement the law. Usually this would be subject to what's called notice and comment. And what that is, in short, is it's an opportunity for the public to weigh in on what is good and bad about the proposal, to oppose bad proposals, to raise concerns, to make recommended changes, to support good things. And Congress said that CMS, the agency that governs Medicaid, does not have to seek public input for this at all. I want to talk a little bit about the cuts in this law that target lawfully present immigrants. It's worth noting that undocumented immigrants the people who push this law have said are one of the targets of the cuts, have not been eligible ever for federal Medicaid funding. And what this law does instead with regards to immigrants is it restricts what was already really limited coverage for lawfully present immigrants. So going forward, a very small set of lawfully present immigrants will be eligible for Medicaid, the Children's Health Insurance Program, Medicare, and marketplace subsidies. These are lawful permanent residents, essentially green card holders, certain Cuban and Haitian entrants, and COFA migrants. This is the Compactive Free Association from Micronesia, Palau, and the Marshall Islands, but it cuts out a lot of people who were previously eligible, such as individuals granted asylum in the United States or withholding of removal. Refugees are now cut out of coverage. Survivors of domestic violence are cut out of coverage. Survivors of human trafficking, and people with temporary protected status and valid visa holders, all of these individuals are newly ineligible for coverage. States will retain the option to cover lawfully present pregnant women and children, but these cuts are going to be really, really damning and really, really harmful. The cuts for Medicaid and the Children's Health Insurance Program go into effect next fall. And Medicare, those cuts have already gone into effect, although those who were already enrolled in Medicare as of the 4th of July, which is the date that this law passed, can remain covered for 18 months. I want to talk really, really briefly about some of the changes to Medicaid financing and cost sharing under the law. This law severely limits the ways that states can raise funds to pay for their share of Medicaid costs, because the way Medicaid is financed is that it's a federal state partnership, and states have to come up with a portion of Medicaid funding too. And this really, really restricts mechanisms like provider taxes and also things called state directed payments, which help states bump up things like reimbursement rates for providers who need that incentive in order to continue serving Medicaid beneficiaries. It also will reimburse Medicaid, emergency only Medicaid for certain immigrants based on the state's base matching percentage instead of what has been a higher percentage rate. And essentially, what this will do is it will really punish states who are following federal requirements to cover these individuals who are not otherwise eligible for full scope coverage in emergencies. It also requires cost sharing of most services up to $35 per service for individuals who are between 100% and 138% of the federal poverty level. And this will really be a deterrent from accessing services. The law also includes a provision that blocks certain abortion providers from federal Medicaid funding. It bans prohibited entities from receiving Medicaid funding for a year. These are entities that are 501c3 tax exempt, that are defined as essential community providers primarily engaged in family planning services, reproductive health, and related medical care, that provide abortions beyond the narrow Hyde Amendment exceptions of rape, incest, and endangerment of the life of the pregnant person, and received over $800,000 in Medicaid funding in fiscal year 2023. And this includes affiliates, subsidiaries, their successors, and clinics. So Planned Parenthood, which is a major provider of reproductive health care, not just abortion, but also preventive services, prenatal services, really critical community providers, were really the target of this law, but it has also impacted other abortion providers like Maine Family Planning, and they have filed suit to challenge this provision. I'm not going to get into a lot of the details of the marketplace cuts in this law. We already discussed how OBA limits eligibility uh, for affordability protections for lawfully present immigrants. But I do want to name that this law failed to expand the enhanced premium tax credits that have helped in recent years make marketplace coverage affordable to millions of more people, and also knock out a number of other affordability protections in the marketplace. So, what does all of this mean for reproductive justice, and how does all of this operate as reproductive oppression? Well, all told, we're looking at $1 trillion in cuts to Medicaid. These are, again, unprecedented. This is the biggest cut in Medicaid's history. There is particular targeting here of Medicaid expansion states, and states will be forced to fill the huge budget holes that are left in their state budgets by making changes. There's no real way to make up the difference through things like raising taxes. And so they're going to have to consider things like cuts to additional cuts to eligibility, optional benefits, and supplemental programs, as well as cuts to other state programs that are really critical. They're also going to see increases in uncompensated care in communities. And what we're going to see as a result of this is the closure of hospitals, clinics, labor and delivery units, particularly in rural and underserved areas, which will further compound access issues. So what does this really mean for healthcare access? Well, the Congressional Budget Office estimates that 11.8 million people will lose health coverage by 2034 due to the Medicaid and Affordable Care Act coverage cuts. Another 7.3 million people will likely lose subsidized health coverage eligibility at the end of this year because Congress failed to expand the enhanced premium tax credits I mentioned. And who will be hurt most? This is Black, Indigenous, and Latina communities, including immigrants, people with disabilities, and rural communities. The abortion provider coverage exclusion that I mentioned will leave the most vulnerable people with nowhere to access care. Family planning clinics are often the only source of care for people with low incomes. Often this is an individual's only healthcare provider. And 76% of Planned Parenthood health centers are located in rural or medically underserved areas. Over 42% of people of reproductive age already live in areas with provider shortages. Almost half of all US counties have no OBGYN. We're seeing an onslaught of attacks to sexual and reproductive health care. Unless you're under a rock, I'm sure you are aware that this has been a soaring challenge in our country in recent years, and this will compound the impact of things like jobs, which has exacerbated abortion care shortages. States with abortion bans have seen a sharp drop in the rate of prescriptions for contraceptives and access to maternal health care providers. Title X, the family planning grant program, on the federal level has been flat funded for 10 years. There's a funding freeze in effect this year that the Trump administration put in place. And just this summer, the Supreme Court decided a case called Medina versus Planned Parenthood of South Atlantic that basically said that the the freedom of choice provision in the Medicaid Act, which allows people to select a family planning provider of their choice, that is no longer enforceable. Medicaid cuts are, let me be clear, reproductive oppression. And I'm going to walk through some of the ways that this is true. First of all, through these cuts, Congress has asserted state control over people's reproductive lives. By cutting off access to care before, during, and after pregnancy, the government asserts control over who is able to access care and when, reinforcing its control over reproductive decision making and disproportionately harming Black, Latina, other people of color, immigrants, and rural communities. The cuts also deny the human right to parent with dignity and support. While pregnancy-related Medicaid eligibility remains, coverage rollbacks will hurt parents and people planning or hoping to prevent pregnancies, reducing access to pre-pregnancy preventive and mental health care that is really critical to maternal health and the health of people with reproductive capacity. As well, the loss of parental coverage from things like work requirements will destabilize children's coverage status and hurt intergenerational health. This is because even though the cuts do not apply to children's eligibility for Medicaid, research shows that parental insurance status is a determinant of children's insurance status. And so children are less likely to be enrolled in coverage if their parents are not. As well, we're seeing through these cuts a structural deterrence from seeking care. Things like increased cost sharing, caseworker discrimination during work requirement exemption processes, and the confusion we're already starting to see regarding eligibility, especially as these different changes become effective in the coming years, will discourage people from accessing critical sexual and reproductive health care services. As well, the structural divestment from reproductive healthcare access will collapse reproductive healthcare infrastructure. Medicaid eligibility losses will cause uncompensated care to soar, leading to hospitals, including labor and delivery units and clinics, to shut down, especially in rural and underserved areas, and divestment from abortion providers, even though Medicaid already only funds abortion in very limited circumstances due to the Hyde Amendment, will deny access to preventive sexual and reproductive health care access for undervalued communities. This is reproductive oppression by design, not by accident. Policies to cut health coverage are not just administrative shifts, they are mechanisms of control over which people are valued, whose parenthood is supported, and whose communities are allowed to thrive. These healthcare cuts have helped to fund tax cuts for the wealthy and corporations, massive increases in funding for racialized mass deportations and border enforcement, and enhanced surveillance and incarceration infrastructure. And what was gained from all of this, despite the claim that the goal of these cuts was to rein in federal spending, we have a increase in the federal deficit as a result of this law, and more power for institutions that power reproductive oppression, such as ICE, uh, Customs and Border Protection, and carceral systems. So, how do we move forward? What would a different vision for federal healthcare reform look like? I'm going to share a blueprint for shifting reproductive oppression to reproductive justice in federal healthcare reform. And I'm going to share that blueprint, which is the reproductive justice principles for federal universal health coverage reform. So, first, a bit about our Medicaid and Reproductive Justice Collaborative at NHELP. This is NHELP's movement lawyering and advocacy hub for our core national reproductive justice partners. We work in service of our partners' vision and take direction from them. And we develop frameworks together, advocacy tools, and trainings to advance reproductive justice and address reproductive oppression in Medicaid and federal healthcare reform. Current members of the collaborative include advocates for youth in our own voice, the National Black Women's Reproductive Justice Agenda, the National Asian Pacific American Women's Forum, the National Latina Institute for Reproductive Justice, and URGE, Unite for Reproductive and Gender Equity. And this table and Help first started convening 7 years ago, and I've had the privilege to help convene it for almost 6 years now. And it's really been a privilege to work with these groups and learn from them. So, what are the reproductive justice principles for universal healthcare reform? Well, this policy tool was created by the collaborative in recognition of the 30th anniversary of the reproductive justice movement. Our principles are for policymakers and aim to build on the reproductive justice founders' vision for healthcare reform that was articulated in the letter I mentioned earlier to Congress, Black Women on Healthcare Reform. This policy product centers the vision, needs, and leadership of the communities most impacted and targeted through structural violence in federal healthcare policy. And we also developed accompanying reproductive justice values for federal universal healthcare reform that are available in 9 languages for a community audience. So, what are the reproductive justice principles? The first of the principles is that all people in the United States experience the human right to universal health coverage and access, including access to culturally and linguistically appropriate sexual, reproductive, and gender affirming health care. Universal health coverage means that everyone living in any US state or territory should have access to health coverage and care that reflects the other principles I'm going to talk about, regardless of race, ethnicity, sex, including things like gender identity, national origin, immigration status, or length of stay, migrant status, language, disability, age, income, fat phobia, or any combination thereof. This human right encompasses a comprehensive range of services, which I'll talk about, necessary to support physical, mental, and social well being. And under the International Human Rights Framework, this unequivocally includes uh, abortion and gender affirming care. And by firmly establishing healthcare as a fundamental human right within the framework of reproductive justice, we resolutely affirm the intrinsic dignity and worth of every individual. The second principle is that under-recognized communities are equitably represented amongst policymakers. Equitable representation needs to happen at every level of healthcare decision making, including policymaking, to ensure that universal healthcare reform truly serves all communities, particularly those who have historically been marginalized and under-recognized. The third principle is that under-recognized communities' concerns and vision guide reform throughout design, implementation, and evaluation. Meaningful community engagement at every stage of the universal healthcare reform process is crucial to ensure that we are working toward a more inclusive, effective, and equitable healthcare system that fosters reproductive justice for all, because the people closest to the problems are closest to the solutions. The fourth principle is that all people should be liberated from healthcare discrimination. Achieving reproductive justice requires freedom from discrimination or coercion. Historically and presently, communities have faced heightened discrimination, bias, and neglect within our healthcare system based on perceived characteristics such as race. And reform has to build and expand upon current non-discrimination protections, such as those included in the Patient Protection and Affordable Care Act, which is not just a health insurance law, but is also a civil rights law. And the non-discrimination provisions in the Affordable Care Act really mirror what the reproductive justice movement mothers talked about in their letter to Congress in 1994, but we need to go even further. As well, coverage has to include comprehensive benefits that meet all healthcare needs. Centering reproductive justice in reform means eliminating benefit coverage gaps and providing coverage without any annual or lifetime limits. The current Medicaid program provides a really important baseline to serving individuals with low incomes and their unique needs, and is actually much more comprehensive than what Medicare includes. So when people talk about Medicare for all, they're actually talking about something a lot less comprehensive coverage-wise than what Medicaid for all would give us. Um, some of the service areas that this has to include, I've outlined here, and you can learn more by reading the principles. The next principle is that healthcare has to be affordable for everyone. Things like premiums, deductibles, co-payments, such as the co-payments that are now required in Medicaid as a result of the One Big Beautiful Bill Act, prevent meaningful access to healthcare services and should not exist for low-income people, including current Medicaid enrollees. Cost sharing should not exist at all. We need meaningful protections for people with disabilities, people with chronic conditions, and others who may have heightened healthcare needs that can really be quite expensive. And any costs to accessing healthcare should be limited to those with the highest incomes and should be reasonable and predictable for individuals and families. Next, healthcare should be confidential for everyone. To protect the right to bodily autonomy, all people, including minors, must be able to make confidential sexual and reproductive healthcare decisions, especially when trying to access stigmatized services. Things like parental consent requirements stand in the way of bodily autonomy and should not exist in our health policies. Amidst the increasing issues of pregnancy surveillance and criminalization, individuals have to be able to access care without the fear of legal repercussions or immigration enforcement, and minors should have the right to access sexual, reproductive, and gender affirming care services without parental or guardian consent or notification. Strengthening patient privacy protections is crucial to minimize the use and disclosure of protected health information and preempt state laws that undermine these fundamental human rights. As well, people should have uninterrupted access to care and the ability to enforce their rights. This includes things like court access, robust due process protections, regardless of their ability to afford things like legal counsel, they should be able to enforce their rights. Um, no one should be denied healthcare, including sexual, reproductive, and gender affirming care services due to an institutional or individual provider's biases or personal beliefs about the morality of services. Reform should include a right to receive immediate referrals to things like sexual, reproductive, and gender affirming care services if needed, and know whether network providers are religiously affiliated and what services these providers refuse to offer. The issue of religious refusals is major in our country and predates Dobbs. Many communities have been without meaningful access to care because of these refusals, and that has to be addressed through federal healthcare reform. And uh, there also needs to be robust requirements for public education and outreach for these mechanisms to be effective. People need to understand their rights and how to enforce them when they are violated. Has been neglected in many healthcare reforms. Outreach and education and know your rights types of activities have really been underfunded if they're included at all, and it's really a critical part of reproductive justice in healthcare that people understand their rights. In conclusion, the One Big Beautiful Bill Act's healthcare cuts are not mutual. They are not neutral. They are reproductive oppression, a form of structural violence. These policies are not isolated harms. They reinforce historic patterns of exclusion, divestment, and control with racialized, gendered harms. The current moment calls not just for critique, but for reimagination and to build an equitable healthcare system. Our government must center the vision, leadership, and needs of people most impacted by structural violence, including reproductive oppression. And the reproductive justice principles for federal universal healthcare reform offer a transformative blueprint for doing just that. I have shared here and will share my PowerPoint afterwards, just some resources, links to the National Health Law Program's landing page for our sexual and reproductive health work, and some of our issue-specific resource hubs. Our hub on our work on sexual and reproductive health equity and justice, which includes the Medicaid and Reproductive Justice Collaborative's publications from the last 7 years, our reproductive justice hub on our work at the interface of federal and state healthcare reform and sexual and reproductive health, an intersection that NHELP has been working at for decades, and the link to sign up for our newsletter to learn about new developments and advocacy opportunities. I also have linked to the websites of the members of the Medicaid and Reproductive Justice Collaborative so that you can learn more about their incredible work to advance reproductive justice in our country. And, oh, sorry. And if you have questions or want to reach out about collaborating, you can email me at my email address, morcell@healthlaw.org, which is in the upper left-hand corner. You can connect with NHELP online. I've included our website and our handles for our Facebook and Blue Sky accounts. We're also on LinkedIn. And thank you so much for having me. I have some time to answer questions. All right. I am just looking at the chat. I see a comment from Kilia. I can't express how refreshing and important it is that you are direct with your language of harms throughout this presentation, such as saying Medicaid cuts are reproductive oppression. I think this is really important. As you point out, language matters. And I think that oftentimes we water down our advocacy by using terms that imply that the injustices in our healthcare system and other injustices in our country are naturally occurring. A great example of this is the term healthcare desert, which suggests that communities that go without healthcare access do so because of naturally occurring forces and not as the result of policy choices. I think it's really important that we embed accountability in our work. Um, Thank you, Lindsay. Okay, I have a question for how far do EMTALA protections go with the implementation of OBA? Rural hospitals will close or contract services, especially labor and delivery. If a pregnant woman needed emergency care, but her closest ER isn't equipped, or she has to travel for care, would she have any legal standing under EMTALA? This is a really hot wire issue in recent years, particularly post Dobbs. And there has been a lot of litigation around whether abortion can be emergency stabilizing treatment. For people that aren't aware, EMTALA stands for the Emergency Medical Treatment and Active Labor Act, and it requires that if someone shows up to a hospital in a medical emergency, they must provide stabilizing treatment to stabilize the emergency condition. And historically, abortion has been one such example of stabilizing treatment, but this has just really been a landmine, and we're seeing more and more a pushback on whether abortion can be stabilizing care. Yes, I will definitely share the slides. Um, all right. I love this question. How do you practice self-care while doing this important work in the face of these complex challenges? This is such an important question. I have learned, like so many of us in this work, the hard way through cycles of burnout, that we absolutely have to take care of ourselves and our communities in order to be able to stay in the work long term. And so for me, this is things like getting enough sleep, therapy. This is spending time with community and people who fill my cup. This is things like really pouring myself into the hours that I'm working. And then when I'm not working, really centering things that feel restorative and give me joy. And another form of self-care that I picked back up in the last couple of years that has been really helpful is creative writing. And I have found that exploring themes of, what is the luminous potential of liberation in our world, um, is really restorative for me. Let's see, seeing if there are any Oh, Katie, hi. Thank you so much for joining. I see a question from Maisha. Lots of students get denied coverage at the University of Minnesota. Is there a reason for this? It forces parents to include them on their insurance plans. Many of young ladies here feel their rights to their bodies are being trampled on. I think there could be a couple of things at play here. Number one, there is an issue um, with university health plans often having limited scope sexual and reproductive health coverage that is just a lot less robust than what is available on other plans. So that is an issue. And then the other piece here is that the Affordable Care Act expanded eligibility and the ability to stay on parents' plans up to the age of 26. And this has had a really measured positive impact in terms of more young people having health coverage when they used to not be eligible to stay on those plans and so went without health coverage oftentimes. And there are a lot of privacy issues with still being on your parents' plan. And so I think this goes to the need for not only enforcement of the privacy protections that already exist, but more robust privacy protections in healthcare. Sydney asked, could you talk a bit about gender affirming care and parallel federal attacks on transgender and gender diverse folks right now, and how that would connect to these federal healthcare cuts in any way? Um, so there's a lot happening in this space, and a lot of it is administrative from the Department of Health and Human Services under the Trump administration. One of the things that we're seeing is a targeting of children's hospitals that are providing gender affirming care services. And as a result of that, some hospitals have stopped providing services, which is going to be devastating and frankly deadly for a lot of young people. What these healthcare cuts will do is that they will restrict eligibility. And in doing so, they will cut off coverage for gender affirming care for a lot of people. It's worth noting that there was a proposal to include in this law a ban on marketplace coverage for gender affirming care, and that was successfully fought and ultimately didn't make it into the final version. And that is largely thanks to the incredible leadership of Two-Spirit, trans, non-binary, and intersex organizations. Yeah, happy to share the source about almost half of US counties not having an OB-GYN. Um, Happy to, I think there's probably time to answer one more question if folks have one, otherwise we can wind down. All right, thank you so much for having me.
Thank you, Madeline. I think this has been incredibly eye-opening and also challenging for the work that a lot of us do, as well as just our regular lives, right? As folks with uteruses and folks that know people with uteruses. So, um, oh, there's a question about, can you repeat the information about gender affirming care?
Yeah, there was a proposal to cut gender affirming care coverage to basically ban gender affirming care coverage in certain health programs. And fortunately, that was removed from the final version of the One Big Beautiful Bill Act, thanks to the incredible leadership of 2STGI advocates and coalition work that they really spearheaded. Um, and there have been numerous attacks on gender affirming care access and just attacks on the existence of Two-Spirit, trans, non binary, and intersex people by the Trump administration, one of the first actions of President Trump was issuing an executive order that denied the existence of trans people. And we're really seeing targeted, widespread, extremely harmful attacks. And it's worth noting that access to gender affirming care and the reproductive justice principles talk about this. This is a bodily autonomy issue. This is a reproductive justice issue. Wes asked, how can I get involved in these programs to help? Sign up for our listserv. We share advocacy opportunities such as proposed rules and opportunities to comment, as well as policy developments and ways to get involved on legislatively as well.
Awesome. If you are able to, Madeline, could you put your contact info into the chat?
Yes,
Um,
absolutely. And it is also in my slides, which I will share.
Yeah. So I put my email into the chat as well. If you are looking to get the slides directly, please reach out to me or to Madeline directly. I hope this was helpful. We do have another Justice and Public Health event planned for November, which will focus on colorism. So we're excited to continue these conversations, and I hope it's enriching. Thank you, Madeline, for your time, your energy, and your work in general. Please continue to support Madeline and other advocates. And y'all, say the things, right? Thank you all for your support. We'll have everybody dismissed, but have a great day. Thank you all.
Thank you, Lauren.